Nazli. It was for your kind introduction, and it's my pleasure and honor to really be able to present to you all. Like Nazli has said, I was really looking forward to interacting with the Pakistan membership. Unfortunately, as you know, with COVID and everything, travel has been restricted. So I've not had a chance to come and see you all in person. I'm going to meet Nazli very soon when she comes to the RCOG World Congress. And I hope many of you are attending. And please do come and find me and say hello to me, because it would be lovely to meet you all when you come to UK. But other than that, let's start with the presentation. And, if you're not clear about anything, you can ask me. So am I able to share? You can see it, I presume. Okay. So I've been asked to talk about the labor ward hierarchy in the UK and the training system in the UK. And I hope I fulfill all that has been asked of me. I work at Macclesfield Hospital, which is part of East Cheshire Trust. It is a place just south of Manchester. And I also am the South Asia representative on the RCOG Council, but I also am a deputy phase 2 lead for medical students. So I'm very much into teaching and training as well. So let's start with what staff are available in delivery. So the terms used for labor ward are labor ward itself. We also call it delivery suite. Or some people call it a birthing suite. So these are all very interchangeable depending on which hospital you work in. But it's very much a multidisciplinary team approach in UK. So the staff predominantly consist of midwives in a labor ward. So midwives, I'll explain to you what sort of patients that midwives see and manage. Other than the midwives, there are the maternity support workers. And maternity support workers are basically there to support the staff in labor ward, mainly the midwives. And I'll explain a little bit about that as well. And you know about the obstetricians and gynecologists who are present. So it will range from first on call, second on call, and third on call doctors. And I'll explain that to you again. Other than that, there are the neonatal nurses, neonatologists, sonologists, and obstetric anesthetists. So I don't know whether you are aware of the situation in UK currently. There have been quite extensive review and scrutiny on maternity services in UK. And a few reports have come up, and these are the Ockenden and Kirkup report. And they have looked at the ways of working on the labor ward. And one of the predominant things which has come out of it is that multidisciplinary team working and training together. So it is very important that you are aware that these are the cadres of doctors and healthcare workers available on a labor ward and contributing on a labor ward. So the obstetricians that are present on the labor ward, there are first on call doctors, second on call doctors, third and possibly fourth on call doctors. So let's start with the first on call doctors. So they can be obstetrics and gynecology trainees. So they are specialty trainees who are into the training program in obstetrics and gynecology. So they are called ST1 and 2. These are the ones who are just starting to work in obstetrics and gynecology and are interested in pursuing the career in obstetrics and gynecology. But other than that, there are other doctors who can be on the first on call rota on the labor ward. And these are foundation year 2 doctors. Now, just let me explain about foundation year 1 and 2. So it's very similar to the internship that you would have following your basic MBBS in Pakistan. And then you would have 1 year of internship. Rather than having 1 year of internship in UK, there is 2 years of this foundation training. In the first year, foundation year, year one doctors do rotation in medicine and surgery, while in year two, they do in various other specialties, and they can, in their rotation, do obstetrics and gynecology. These are the doctors who would be first on call. And then we also have these GP trainees. So people who want to become general practitioners, but then have a rotation system in the hospital, and they might be rotating into obstetrics and gynecology. So the first on-call doctor basically does simple stuff like putting in cannulas, taking bloods, prescribing medication, prescribing IV fluids, assisting in cesarean sections, assisting in, in theater and things like that. If it's a specialty doctor in obs and gynae, then they would be learning to do cesarean sections, instrumental deliveries, and assisting and learning the skills for obs and gynae. But we wouldn't expect the same from a foundation year 2 or GP trainee. So there is a little bit of discrepancy on what their requirements are. But these are the first on-call doctors, and they are present in labor ward all the time. Obviously helping with labor ward work, but also other obstetric work like looking after antenatal patients, prescribing postnatal patients, and things like that. And they are resident on call. So you will have somebody covering from 8 to say 8 in the night, and then from night 8 to 8 in the morning. Now coming to the second on-call doctors. Second on-call doctors are more senior obs and gynae trainees, so specialty level 3 to 7, and they are in what we would call registrar cadre. So they are second on call doing more complex sort of stuff like delivering, doing the cesarean sections, emergency cesarean sections, instrumental deliveries, looking, if there's a PPH, they would be the first ones to be called, and things like that. They would be there on site. So they again are resident. They're present all the time, 24 hours. Obviously, there's a shift system, and they would change over after every 12 hours or so. And they manage most of the labor ward issues. But other than people who are on the training pathway, there are standalone doctors, like locally employed doctors, LED doctors, these are called. And these might be doctors who come from overseas. And those are basically the ones who, perhaps coming in from Pakistan, you want to come and work in the UK, so you get GMC registration and come and work, but you've already done your post-graduation perhaps in Pakistan, so you are already quite experienced, you've done post-graduation, worked for some time, and then want to come. So you can come, but obviously you need to start as a first on call for some time while you gain the skills, and then you can become the locally employed doctor on the registrar rota, on the second on call rota. And then we've got non-training posts, which are staff grade and associate specialists. Which are called SAS doctors. We don't have associate specialists anymore. We have specialty doctors. These are again standalone posts, which are not in the training pathway, but still, you are working on the obs and gynae, on the labor ward, but also doing quite senior stuff rather than very junior stuff. And obviously, what I have not mentioned is all these doctors will also have some gynae experience, not just labor ward. Right, looking at the obstetrician consultants. So there are two types of consultants. One is resident consultants and then non-resident consultants. So in UK, we have got various sizes of hospitals, NHS hospitals. NHS stands for National Health Service. I'm sure you are aware of that. So the smaller hospitals and small to medium-sized hospitals are called district general hospitals. And the more research active and bigger centers are called tertiary centers. And in the tertiary centers, you might actually find that there is a 4-tier rota where there might be a first on call, second on call, and then you would have a resident consultant who again would be on site 24 hours. And then you would have a non-resident consultant from home. And there might also be combinations of rotas where you would have a resident consultant covering obstetrics. non-resident consultant who's covering both obstetrics and gynecology. But in a smaller DGH, District General Hospital, like I work in, we have got a non-resident consultant. So I'm on call from home. I'm a resident in the hospital till 5 o'clock. Then I come home and then I cover the on-calls from home. So if there's a emergency like a postpartum hemorrhage or if there's any maternal collapse, then I'm called in and I need to be there within half an hour. But with Auckland report, like I mentioned to you before, we are going to be on site for longer. So our rotas are going to change so that we'll be on site from 8 o'clock to 8 o'clock in the night and then come home after that. I hope it's clear so far. So next is midwives. I said midwives play a very big role in UK. It's not the same, I know, in some most countries. I know in Pakistan, it's mainly doctors who deliver. But in the UK, midwives have a role. And the data from NHS Digital has actually shown that there are nearly 22,000 midwives currently. And that means there's one midwife present for every 30 births. And the role of the midwives basically is to manage the low risk pregnancies. So what happens in UK when women book early in pregnancy, in the first trimester of pregnancy, they book with and then when they do book, they are classified either as low risk or high risk. So the low risk are very straightforward pregnancies, no other risk factors. The risk factors we are looking for is something like high blood pressure, diabetes, for example, or some other underlying medical problem and things like that. Anybody with any underlying medical problem or an ongoing medical problem will be classified as high risk, and they would come under consultant-led care, and they would be seen in the hospital in the antenatal clinics. While the low risk pregnancies are fully midwifery led care. So they are seen antenatally by midwives, they are managed antenatally by midwives. And then when it comes to the birth, they are managed by the midwives. So the doctors do not have any role in the management. But for example, if a low risk pregnancy develops some problems, like say somebody who's low risk then develops preeclampsia, then they would be transferred to hospital-led care or consultant-led care, and then they become high risk. So I hope I'm clear so far. So I was telling you about the maternity support workers. There is another category of workers called maternity support workers, which work alongside qualified medical staff. They're vital to the smooth running of maternity, and they support maternity services. They mainly support the midwives, but doctors as well, and support neonatal nursing, housekeeping, and clerical staff. So these are all the support staff, which is very essential for smooth running of a labor ward. What about neonatal nurses? It's just a quick one. They are part of the MDT, as I said, and they work alongside neonatologists and allied health providers. The neonatal workers, nurses generally look after babies from 23 weeks to 44 weeks of gestation who have complex needs such as intensive respiratory support, complex surgical procedures, or ECMO. And the nurse to baby ratios, which is recommended for intensive care, is 1:1, high dependency 1:2, and special care baby unit 1:4. So these are again part of labor ward MDT. Now let's look at where the births happen. Where do these women deliver? So home birth is quite popular in the UK, and home birth is possible for low risk women who start off low risk, continue to be low risk throughout their pregnancy up to the delivery time. And home births are conducted by midwives, and generally 2 midwives attend when a woman births at home. And these women are never come in contact with doctors because they continue to be low risk. Then we have birth centers. Birth centers are again midwifery-led units. So midwifery-led units, so these birth centers can either be within the main hospital. So in an NHS hospital where there's delivery suite or a labor ward, there might be birth center within the hospital, which is managed by midwives solely. The advantage of having it within an obstetric unit is that if there's a complication or slow progress in labor, the midwifery-led unit patient can be transferred to the obstetric unit managed by doctors and midwives. So it's very quick to transfer. But there are some freestanding units which are like within half an hour distance from the main hospital or main obstetric unit. And they then, if they need any more support, they are transferred via ambulance. And then we are talking about the obstetric unit or the delivery suite or the labor ward, which is manned by, again, midwives who are looking after these women when they are in. So each woman gets a room, labor ward room, when they are laboring. And each woman is looked after by a midwife. The doctors, the first on call and second on call doctors, hold a bleep. And when so midwife is looking after the CTG runs, the labor progresses. If there are any problems with the labor, then she calls the doctors to come and have a review, and the doctors review and then decide what the plan of action should be, whether they need oxytocin to be started, whether they need an instrumental delivery, or whether the CTG is abnormal and they might need a cesarean section. So that is how it works in the UK. Now, if it's a complicated patient and the second on call is not confident delivering the baby or managing the patient, then they will ring the consultant to come in and help out. Right, let's look at the training now. Before I start about training, I know not many have joined online now, but do you have any questions so far?
If anybody has any questions, please feel free to directly interact with Jyotsna.
Has it been clear so far, Natali?
It is wonderful, actually, very, very nice. I think you're very comprehensive, and it's going to help all those who are even selected for MTI this time, and they're going to come there and work. It has been really helpful, very nice.
Thank you. I don't think there are any questions, isn't it? Are there any questions?
There is one chat. So they said, yes, it's clear. There is a comment that, yes, it's clear.
Okay.
So no questions.
Okay, so I'll proceed then on training. Okay, so going on to training. So I'm sure you must have seen this on the RCOG website. This is the structured training program for obs and gynae in UK, and this is on the Royal College of Obs and Gynae website. Now, you know how in the beginning I told you about the foundation year 1 and 2 training, which lasts for 2 years. So that's the first one here. So any doctor who has completed their initial MBBS would need to do this foundation year 1 and 2. And generally, obs and gynae is covered in foundation year 2. Once they have done that, and if somebody is very impressed by their rotation in foundation year 2 and want to apply for obs and gynae training, then what they would do is they would apply for specialty training. So they would apply for ST1 level, which is specialty training 1 level, and they would get a national training number. And then they would, once they get into ST1, then it's run through training. So they would complete at ST7, then they would get their completion of training certificate, and then they would become consultants. So it's run through after that. So it's quite straightforward. Now, the ST1 and 2 is classed as basic training, ST3 to 5 is classed as intermediate training, and advanced training is ST6 and 7. The only caveat with this run-through training is you have to pass Part 1 MRCOG exam before you can actually go on from ST2 to ST3. If you don't pass it, then you stay on ST2 and you are given 1 year grace period. And if you fail to pass, you are then taken out of the training system. So you have to pass the exam. After ST5, you need to pass MRCOG Part 2 and 3 exams before you can proceed to ST6 and ST7. Again, similarly, you will get some grace period. You'll get 1 year. If you don't pass, then you are then taken off the program, and then you might have to start again, or look for other ways to do it. But generally, people tend to pass. Now, so the intermediate training is when you are a junior person who's a second on call. You get a lot of support from the consultant, or if you have a resident consultant or a senior trainee, on the third on-call cadre, then they will help you learn the skills like, again, like doing cesarean sections, instrumental deliveries, evacuation of retained products of conception, manual removal of placenta, and things like that. ST6 and 7 are the ones where you would develop a special interest, really. So you would pick up what we call ATSMs, which is Advanced Training Skills Modules. And there are obstetric ones and gynae Advanced Training Skills Modules. And you might then decide, what you want to do. So if you want to pursue more specialized obstetrics, then you would take maternal medicine module ATSM and do labor ward ATSM or labor ward lead ATSM. If you want to do more gynae, you would do benign gynecology or maybe vulval diseases or things like that. If you want to be even more specialized and work in a tertiary care hospital, then you would want to do subspecialty training and you apply for it competitively. The subspecialty training basically is either urogynecology, fetal medicine, or gyne-oncology, and so on and so forth. So this is the training system for somebody who has done their MBBS and Foundation Year 1 and 2 in UK. What about if you wanted to come from abroad, come from Pakistan, let's say, and want to join the training program? So let's look at what you could do. So if you wanted to do that as an ST1, so you want to join as a first level, junior level ST1 Ops and Gynae in UK, you can only do that if your maximum experience in Ops and Gynae is 24 months. So that rules out anybody who's done any post-graduation in Pakistan because you automatically do more than 24 months. But if somebody is just starting out their career and think, I want to do Ops and Gynae, but I want to do it in UK, it might be suitable for you. So what I would suggest is these are the prerequisites. So maximum experience is 24 months. If you suit that, then you can apply for ST1. But it is always helpful for you to first gain the GMC registration, come to the UK, do a standalone post, and then apply for ST1. Because it's better to get some UK experience because there are some criteria you need to fulfill to apply for ST1 level. And I would guide you to look in depth in the health education website, Health Education England. It is called HEE website. If you just put in ST1 Ops and Gynae Health Education England, you will be taken to the site and you will see all the prerequisites that you need to apply for an ST1 post. And it is good if you are successful in getting into an ST1 post. There's a run-through program. You come out, you become a consultant in UK, and you are trained in the UK system. So it is very suitable for somebody who's very keen to do that. And I mentioned this already, the internship is 1 year in Pakistan. So you might need to, I think it would be ideal if you could apply and come and do your second year of work in UK in any hospital, and then you get the UK experience as well, and then you are more equipped to for the interview. But if you can't do that, you can still do 1 more year in Ops and Gynae in a training hospital in Pakistan and then apply for ST1. For you to be able to eligible, you need a certificate of readiness to enter into specialty training. What they want basically is somebody who's either very senior consultant in Pakistan or a consultant in UK to give you a certificate, and you should have worked with them at least for 3 months in the past 3.5 years. And they can say, this is a competent doctor. I have no problems in recommending this doctor for ST1 level. That is what you need. And you also need full GMC registration with a license to practice before you apply for the ST1. And that is why I said it might be helpful to come to UK, get your registration, pass your PLAB examination. Next, the third point is the PLAB examination, which is Professional and Linguistic Assessment Board examination, which is held in Manchester. And incidentally, I'm a PLAB examiner as well. So I do see quite a lot of overseas doctors come and do the PLAB examination here. And then it always helps if you're coming directly from Pakistan and not working in the UK to have a clinical attachment, at least in obs and gynae in UK, so that you know how NHS works. You will be better able to answer the questions. And I know this talk is mainly to learn the UK labor ward system, maternity system, but it's not a replacement for coming and working, because if you work, that experience really helps, and it comes through when you are interviewed, and you'll be more success, more chances of success in the interview. So I've just put this is from the HEE website, which I've copied and pasted. So this is exactly what it says on the website. So if you go on the website, you'll have all the information that you require. And they've also given out, contact details, emails, where you can email and ask. So what about ST3? So ST3 level entry is also available now in the UK. And this is more suitable for somebody who's worked in obs and gynae in Pakistan, has done their post-graduation, and then think, okay, I want to go and work in the UK, and I want to do the training in UK. So obviously, you can apply for the ST3 level entry. You would obviously need to have passed your MRCOG Part 1. Unfortunately, anybody who's done it before 2015 is not eligible. So you need to have done your MRCOG Part 1 examination before, after 2015. Don't despair if you've done it before. There are other routes, and I will cover that as well. And you should not have passed your MRCOG Part 2 earlier than 2019. So you obviously, if you're coming as a senior trainee at an ST3 level, you need to show all the ST1 and 2 competencies that you have achieved, and foundation year 1 and 2 competencies. How do you show? There are forms that you can fill, and I'll show you in the next slide. And these competencies can be either achieved in Pakistan, or you can come to UK and achieve them in a standalone post. Right, so these are the competencies that you need to have achieved to be eligible to apply for ST3, and then you can read them yourself. The technical skills are surgical management of miscarriage, non-rotational assisted vaginal delivery, uncomplicated cesarean, manual removal of placenta, perineal repair, opening and closing of abdomen, and fetal blood sampling. Fetal blood sampling is not a must now, because a lot of units in UK actually don't do fetal blood sampling, so that's not a big issue. And if you have done post-graduation in Pakistan, I would assume that you would be competent in all of these, so it's not a big deal really. Then these are other prerequisites that you need. Obviously, you need to have had experience as first on call and then second on call, but you must be developing the competencies for second on call. You really don't need to show evidence of being competent in all of the second on call work. And then you need to have done the basic practical skills in obstetrics and gynecology, which is run by the Royal College of Obs and Gynae, but you can actually show that you have been booked for it. And then you need an obstetric simulation course. These courses are like prompt or also courses, which are again run in UK, but they are run overseas as well, as far as I know. So you can sort of achieve this overseas as well. You need to show that you have taught some your junior doctors or medical students, some evidence of that, and you need evidence of presentations and publications. So, and if you're successful in getting into either ST1 or ST3 level entry, then each year you need to show that you have achieved competencies. So once you get into the training program, you are given an e-portfolio. So it's just all online, and you need to just fill all the things that you need to do, all the curriculum requirements, and show that you have fulfilled it. So your educational supervisor will sit with you and fill all the things that need to be filled. And then we are very big on work-based assessments in UK. So work-based assessments are basically, somebody watching you do an instrumental delivery, somebody watching you do a cesarean section, and then they can say, yes, this person is competent. So initially you would work towards competence, and then you would be signed off for being competent. So or you might have like a case-based discussion, which is called a CBD, where you would see a complex case, you are observed by your senior doctor, and then you both sit together and get it signed off. So if you fulfill all the requirements, and there's a requirement like you need 2 CBDs, or you need so many work-based assessments to progress to the next year. And once you've collected all the evidence on your e-portfolio, you are then, you have an ARCP, which is Annual Review of Competence of Progression, which is done by your training program director and some other educational supervisors who will sit and see your e-portfolio and see if you have fulfilled all the requirements. If you've fulfilled all the requirements, you progress to the next year. If you haven't, then they'll give you some extra grace period to complete that before you progress. But obviously the stumbling block is that you need to have passed your MRCOG Part 2 and 3 before you can progress on to ST6 from ST5. And from ST2 to 3, you need to have passed your Part 1. And once, if you have been successful in passing all the years, then you have your final ARCP, which is Certificate of Completion of Training. You finish that, you go into the specialist register, and you can apply for consultant posts. And that finishes your training. What about those who can't get into the training post, are unsuccessful, or maybe you've done your MRCOG Part 1 or 2 before the dates that they have specified? So for you, the route would be to apply for, do your, you've done your MRCOG Part 1, 2 anyway, and you might want to come and do Part 3 in UK, or you've already passed your Part 3 and you want to come and work in the UK. You apply for locally employed doctor posts. There are other names for it. They are called trust doctors and other names. I've got a slide which I will show to you. So they are locally employed doctors, and then you would apply to these posts. But just a caution for you, even if you are very senior in your work experience, what generally happens is nobody will directly apply, select you for second on call or registrar senior level post. You generally have to come and work in the UK as a first on call doctor for a few months, not for long, just to learn the system, because the system is very different from what it is in Pakistan. So you will know once you come and start working here. So you need to work, I would say apply to a junior level doctor, like a trust grade, first on call post. Come here, get your GMC registration and everything, work for 6 months or so, or even 1 year, and then you can apply for the registrar level jobs, because the hospital you work in will realize that how experienced you are, and then they can recommend you to senior level posts. So this is the specialty and associate specialist posts, which I was telling you about, which are non-training posts. And then if you have worked in the UK in these non-training posts for a few years, what you could do is, I was telling you about the advanced training skills modules. You can actually apply to do these ATSMs on your own. You don't have to be in the training program to do it. So you can decide to do one ATSM, which you get support from your consultant, get signed off. And once you have achieved at least 2 ATSMs, you gather all the evidence of your experience, and then you can enter the specialist register through the certificate of eligibility of specialist registration, and then become a consultant in the UK. So there are other ways, like I said to you. And this is another route to gain entry into the specialist register. So a little bit about the locally employed doctors. These are junior level doctors, which are at specialty level 1 and 3. So you know how I explained to you the first on call doctors. And so the specific trust is also a hospital in the UK. So the hospitals will advertise for these posts. And you can apply directly to that. And the titles that we use is trust grade doctor, trust doctor, clinical fellow, foundation year 3 doctor, or staff grade doctor. And you apply for these first on call directly. And the websites that you look for is this one, www.jobs.nhs.uk, or it's also called tracks.jobs. But if you wanted to apply for more senior level, like a registrar level or second on call, after you've had quite a lot of experience, then you can apply for these more senior second on call. But like I said to you before, I would recommend you to come to UK and work on first on call for a short period of time before progressing on to the second on call. Little bit about the MTI. I know you've already had a lecture on MTI before, but I'll just refresher, and I'll just quickly whiz through this and then I'll complete. I hope I'm okay with time. Yeah. So it allows, so this is one way to come to the UK and gain some experience. And then also, if you are struggling to pass your MRCOG Part 2 and 3, this is a very good avenue to come work for 2 years and then go back to Pakistan and then, you know, set up your own practice and get all the experience you got from UK and use it in Pakistan. These MTI, and I must congratulate Nazli at this point. Thank you so much, Nazli, that you have really worked tirelessly. You've managed to get Pakistan from the bottom to the top in the MTI range, and it was noticed and appreciated. And we discussed that in council, and I did, congratulate you there as well. So thank you so much for doing that, and it's all your hard work, I must say. So it is a real good avenue to come to the UK, I must say. And the way it works is you are in Pakistan, you apply for this MTI scheme, and then you have an interview with the hospital that will interview either on Skype or Zoom or something. And if they feel that you are the right person, then people like Nazli and the fellows in the IRC in Pakistan will interview you as well. And then once they feel that you are ready, then RCOG will sponsor your GMC registration and help you with the 2-year visa to come to UK and work here. So it's a good one to get GMC registration and get the visa through RCOG. And MTI lead, like Nazli was saying, Dr. Sanjay Rao and Dr. Hiran Samange will actually help with all this. Now, the expectation with these MTI, which is Medical Training Initiative posts, is that you come and work at a junior level and then progress on to a senior level as a second on call, sit your MRCOG Part 2, 3 exam, and then go back to Pakistan and work there. Benefits are obviously, like I said, pass the exams, then you can return and take the skills that you've gained in the NHS, like multidisciplinary team working, clinical governance, and evidence-based medicine. And you can then become a part of the IRC in Pakistan. You can be a member, in the committee, and you can participate in things which are run by RCOG. So you're part of the family then. There are some criteria, obviously, to apply. You need to have passed your Part 1 examinations, RCOG, and you shouldn't have more than 10 years of experience, but you do need 4 years of experience. You need an English language test. You need the assessment of training letter from RCOG. And like I mentioned, you need an interview with IRC chair or RCOG fellow, 2 references, and HOD reference. And then this is the website if you're interested, please do look into this. It's mti@rcog.org.uk. And this is just a picture. So that finishes my talk. I hope you found it useful, and I hope people who see it later will find it useful as well.
So, Jyotsna, it's indeed very, very nice talk. And I think before I conclude, I would ask the House for any questions or any comments. Please interact with her directly, because what you learn from her directly is going to be much more valuable than anybody else translating it for you later on.
Assalamu alaikum, Dr. Nazli, Dr. Jyotsna. It was an excellent talk. I am Professor Rehana Rahim. I work closely with Dr. Nazli and part of RCOG IRC team from Pakistan.
कहाँ जा रही है? कहाँ जा रही है?
I must thank.
We can't hear you.
Rehana, we are unable to hear you now. Can you please unmute yourself? And please, all others, kindly mute yourself. When one person is talking, all others are requested to mute themselves.
Can you hear me now, Dr. Nazli?
Yes, Dr. Rehana. Thank you so
Yeah,
much, Dr.
thank you.
Rehana, for joining. Jyotsna, Dr. Rehana is, as she introduced herself, she's an IRC member, very enthusiastically participates in various activities, and in the recent MTI interviews, she worked very closely with me, and I'm very grateful for her. Yes, Dr. Rehana, please carry on.
I just have a little bit of Perry Jacksana. I have worked in UK for about 4.5 years. That was back in 1992 and 1993. NHS probably at that time was working, and the goal towards clinical governance was not the way it is today.
Yes.
So yeah, the only difficult part probably which our students would encounter if they come and join as part of MTI scheme would be the clinical governance bit. So I was wondering whether is there a way that they can be guided, or do you think once they join, they will be sort of going through all these steps and they will learn it before, after joining? Or do you think they need some sort of guidance for this or not?
So, I mean, it's not a prerequisite, Dr. Rehana.
Yeah.
So, governance has changed a lot, as you said. It's
Yes.
moved ahead so much, because I don't know whether you keep abreast with what's happening in the UK now, but have you heard of the Ockenden report and the Curb report and all the things? There are lots of overhaul in maternity services. There's a lot of scrutiny on maternity services, because there were, I don't know, there was because of some maternal morbidity, maternal mortality.
Yes.
Fetal issues. So the Ockenden report and Kirkup report have actually changed how we are working now, So they want consultant presence on labor ward for longer periods of time, MDT working, MDT training. There are lots of essential actions which all maternity units now have to fulfill. Now, coming to the question of clinical governance is such a big topic, isn't it?
Yes.
And I know it is one of the bugbears of anybody who comes from overseas, and those who sit the MRCOG Part 3 exam as well. There's always a question of clinical governance which everybody fears. Obviously, it is something you learn in the process. I didn't know anything about clinical governance when I came from India, so I didn't know anything about it. I learned on the job. But we can, I mean, if you are interested, we can see if we can organize some webinar on clinical governance, just to get an introduction on what it is really, because it's such a big thing and nobody knows. We used to, I remember for interviews, I used to read upon it and get definitions and things like that, which is not what it is really. It's more than that. As you work, you learn more. But just to get an introduction, we could do something like that. But yeah, to answer your question, for an MTI trainee, it's not a prerequisite. They learn that when they come to the UK for the 2-year placement.
Yeah, thank you so much. Thank you so much. But I think, Dr. Nazli, if we can have a little bit of activity regarding this before this team, our selected team goes and joins UK training program, it will definitely help them.
Yeah.
It's duly noted, Dr. Rehana. It's a very valid suggestion. Thank you very much for this. And I think I've made a note of it, and it's definitely we are going to organize one. Any other questions or comments, please? All right. So, Dr. Jyotsna, it was indeed a very informative talk. I think personally, I've learned a lot from it, and what I expected you to contribute, you've done more than that. So, quite a bit of awareness, how the labor room structure is functioning there, and the various nurses levels, like midwives, we didn't know that there's associate midwives as well, and like you said, the neonatal nurses as well. So that will definitely help our candidates when they come there and they work there. Moreover, you also guided us very nicely on, how they have to progress during this training period, how they have to progress from MRCOG Part 1 and 2, 3, and especially mentioning the grace period time as well, so that they don't know exactly, what are their timelines and how can they progress. And there's just one question which I need to get clear on. But you said that for MTI training, it doesn't have to be more than 10 years. When in all the talks that we have held recently, I think it has been redefined at 8 years. Am I right? Or
Oh, it might be. It might be. Sorry, Dr. Nazli. The problem is I've not been into the MTI thing. So you are absolutely right. So sorry, I stand corrected.
So it's okay. So because I repeatedly, I specifically wanted to clarify this on this forum, because repeatedly I get inboxes from various candidates, saying that I've just crossed the 8 years limit, and is there still a possibility that I can get in? And I keep on replying that 8 years in UK definition means 8 years, and it's not,
Yeah,
8.5.
They won't
So,
consider.
and yes, and then we got a very nice clarification on, to your work-based assessments and case-based discussions and annual review, all the review process, and then how final ARCP is done, what is CCT, and what is ATSM. I think this is all. The thing is that all these informations are available on the college website, but when we arrange activities like this, you get a visual reinforcement, you get an auditory reinforcement, and it's very natural that more senses you are using, to capture an information, the greater is that impact, and how more it gets imprinted in your mind. And moreover, you get an opportunity to interact with people like Jyotsna. She's been so enthusiastic. I know her. She really wanted to interact, and I'm so happy that she's here with us today. And maybe she would agree to have another talk on clinical governance sometimes later, depending on her schedule. Thank you so much, Jyotsna. This is a recorded talk, and so there is a question. So one candidate has said, so we have to pass MRCOG2 within 8 years after passing. So it says, so we have to pass MRCOG Part 2 within 8 years after passing MRCOG1. Please confirm, ma'am. So Jyotsna, you want to take this question, or should I answer?
You answer, please. I'm not, yeah.
So I think you're confusing the two things here. What the 8 years cutoff is basically for MTI. If in Pakistan you have done 8 years of training, more than 8 years of training, you are not eligible to apply for MTI anymore, right? So your training has to be under 8 years to apply for MTI. As far as MRCOG Part 2 is concerned, what I have understood from Jyotsna's lecture is that once you are in you are in the ST system, and ST1 and ST2 level. So within those 5 years, you have to pass your MRCOG Part 2 as well as 3 before you progress to ST6 and ST7. And probably that is where you get a grace period of 1 year, depending on the vacancy in that particular hospital, where probably you can clear it. So the 8-year terminology is not for MRCOG Part 2 there. That was for MTI.
Yeah, and can I just clarify there as well? So the 1 year grace period is somebody who's on the specialty training program. They are training. If you are an MTI trainee, or if you're doing the CSER pathway, which is the certificate of eligibility, which you gain your own, you collect all your competencies and apply yourself. For that, there is no limit. There is no limit to how many years you have to progress. And I also would say, if somebody has had more than 8 years of experience in obs and gynae and still wants to come and work in the UK, don't despair. You can't do the MTI route, but I told you, go onto the NHS jobs website and apply for first on call doctor, come to the UK, work for a few months, and then you can start applying for more senior posts like second on call. And then once you start working, in a few years, you gain all the competencies, get all the evidence, and then you can apply for the CSER pathway and then complete your training and then become a consultant. So there are other ways.
Yes, and we have had a session on that as well, different routes for Pakistani doctors in the UK. So the very first talk, if you, Dr. Noor, if you go on the IRC RCOG Pakistan Facebook page, the first webinar, the MRCOG Part 1, the first webinar, IRC Academics 1, was on this, and that covered these alternative routes as well. But I'm happy that you introduced today this locally employed doctors and SAS doctors as well. So you definitely added on to what has already been conveyed to them. So what I do is, generally as the awareness is spreading now, more and more people, they approach me to, get information, and then I share the links of all the activities that we have done. I say, please go through these 5 videos first, and then come back to me, and then question. Because generally there is a tendency amongst people that they want everything to be spoon-fed, everything just direct answering, questioning. So that is, you can only do so much in that category. Somebody has to help himself or herself first before expecting help from others.
Dr. Nazli, you're doing a wonderful job, I must say. Thank you for doing that.
Thank you so much. Thank you so much. And thank you so much for being there with me. Without your support, I'm sure I couldn't have done it. Thank you so much. Really appreciate your presence and your participation. Allah Hafiz. Goodbye.
Bye. Bye.
नहीं किसी और नंबर से था